Thank you very much. I'm very grateful for being invited to give this, and I'd like to welcome you all to Birmingham. I have my disclosures. I've worked with a number of pharmaceutical companies on the design and analysis of clinical trials. The views I express today are my own. I don't benefit from the sale of any of the drugs that I'm going to discuss, and I'd like to remind you that the only licensed drugs for lupus are prednisolone, hydroxychloroquine, and belimumab. So why is the disease called lupus? Many people have asked that over the years. The simplest explanation is that the rash on the face is similar to the rash, or rather the fur, on a wolf. There are other people who say that the name comes from the wolf bites on a face, the untreated scars looking like wolf bites. And there is also a theory that this comes from the French mask called le loup, which of course is French for wolf, which is a mask used to conceal the rash of lupus. Many people think that lupus is a new disease, but it's been recognized for many years. The first descriptions of a lupus rash, with severe rashes looking like a face that's been bitten by a wolf, was described by Rogerius in the 13th century. It was in 1833 that Cazenave first described erythema centrifugum, and that now is felt to be the discoid rash that we recognize in lupus. And the butterfly distribution of the rash over the malar bones and the nose was first noted by von Hebra in 1846. The multi-system nature of the disease was first reported by Kaposi in 1872, and there were a number of papers by William Osler at the end of the 19th century and early 20th century describing the systemic manifestations of lupus. At this time, the only treatments available were quinine and salicylates. It wasn't until the 1950s, with the discovery of corticosteroids as a treatment for inflammatory disease, that much progress was made with treating this disease. But the steroids, as you know, and as I'm going to describe in this talk, have a lot of side effects. And it was the introduction of cytotoxic drugs with azathioprine and cyclophosphamide, particularly for lupus nephritis, that developed in the 1960s to try and suppress the autoantibodies and inflammatory processes that are the hallmark of this disease. Now, William Heberdon was alive in the 18th century, and most people don't think of him as having much to do with lupus disease. He was a meticulous physician who kept very detailed notes of every case that he saw, and his commentaries were written up, and they were eventually published by his son after his death, first in Latin and then in English, and they were entitled The Commentaries of the History and Cure of Diseases, and they were published widely around the world, and there is an edition available on the internet from Boston, published in 1818, that makes very interesting reading. Now, he's particularly known, as I'm sure you're all aware, for his work on arthritis, describing gout, osteoarthritis, and inflammatory arthritis. But there are some cases that he describes during the pages of his commentaries which suggest that he did see patients with lupus, at least in my opinion. He describes several women who had a pimple that appeared on their noses and spread over the nose, the face, and the neck, and defied treatment for many years. And this was more common in women than men. He also described a branny scurf on parts of the skin, particularly the head and the scalp, sometimes associated with hair loss. And this was also thought to be originally psoriasis, but may well be the rash of discoid lupus. He was aware of the fluctuating nature of certain skin rashes with systemic disease, and fluctuations in the skin rashes associating with severe languors, the lack of physical or mental energy, i.e. the fatigue that many lupus patients describe. But he was aware that these conditions were rare. He also described women who had swelling of their legs, not just in pregnancy, and commented that it wasn't often seen in those of the other sex, suggesting that he was certainly aware of nephrotic syndrome, some of which might have been lupus. And he noticed patients who had what sounds like vasculitic rashes that developed into ulcers that were hard to treat. And he was aware of patients with recurrent ulcers, sometimes in association with nerve palsies, fever, and sometimes so severe that it was associated with patients dying. And these recurrent oral ulcerations were particularly common in patients who came from the West Indies to England. Possibly lupus, maybe not. So now I'd like to introduce you to one of the first patients that I'm going to discuss today. This is Nandeep, who illustrates some of the symptoms and signs that I've just described to you.
I was getting very tired, and which I couldn't understand why. And then late November, I started getting vasculitis. So I saw my consultant again, who referred me to you because I think straight away he thought.
And that was
okay,
a more severe rash.
Yes. He thought, okay, it looks like some kind of lupus. I mean, so I was very lucky in that sense that there's all the symptoms, everything all came at once, and then I got a quick diagnosis of, okay, this is SLE. And that was all within the space of like a couple of weeks or months of, well, when I saw you, I think straight away you were like, yeah, this is lupus. So I was very lucky compared to some of the other stories you hear. So then I was transferred back to City. I had my biopsy here. It was like a day thing. I think I come in at night to stay, and then I go have the biopsy in the morning, and I go home in the evening. And I had no responsibilities at home. I dropped out at university. I had no kids. I wasn't married, so my family were looking after me, so I was fine. I just went home and slept. I think I had 6 courses of
Or did you have the 6 courses of cyclophosphamide first?
Yes.
Then went on to the prednisolone and azathioprine.
I think the prednisolone was about 50 mil. When I first got diagnosed, I was on 50 milligrams. And then that was being reduced through the treatment. And I think that the last treatment I had was over the summer, July or August. And then my steroids were probably down to about 25 or something like that. And then you brought the azathioprine in.
Right.
And it went well. It was perfect for me.
And
I went
the
back to
steroids
university.
went much lower, and you went back to university, got on with your career.
Yeah, I finished my degree, and so I was fine. It was like nothing had really happened.
So Nandeep was quite lucky. She did get a quick diagnosis. She had all the typical antibodies and low complements in the blood that often associate with disease. Her biopsy confirmed a class 3 lupus nephritis, and she responded extremely well to a course of intravenous cyclophosphamide and steroids, followed by azathioprine. Some patients don't do so well. They take much longer to diagnose, even when they come from the most closely associated ethnic group with lupus disease, when they're of Afro-Caribbean origin. And this is Angela describing the onset of her disease.
Very long time for me to get diagnosed. I went to the doctor over many years with various symptoms of anemia, joint pain, tiredness, and just general malaise that I just didn't understand. Eventually, when the pains got so bad, I was referred to a consultant. At first they thought it was rheumatoid arthritis, and it still took a further while for lupus to be diagnosed. I hadn't heard of lupus at all. In fact, when I was diagnosed and my illness was given a name, I was so grateful that the pains and the discomforts actually had a name. So I was pleased to actually be diagnosed. Yeah, it was a total shock. I remember being told I had lupus and being suddenly put on steroids and being put on this really strong medication, and I was really pleased that that was happening because at last something was being done to help me. And then I was called in and I was told that there was a possibility of some kidney problems and that I was going to have a biopsy, and the shock was just really overwhelming because I didn't realise, in fact, how ill I had actually been.
And of course, this is often the problem. Patients don't know they have renal disease. Unless the urine is looked at, you're not going to pick up the telltale signs of proteinuria and hematuria. She had class 4 lupus nephritis. In those days, renal physicians treated with high-dose oral prednisolone, 1 milligram per kilogram per day, oral cyclophosphamide for 3 months, and then she was switched to azathioprine. And we'll come back to the outcome of her disease a bit later on. Some patients have other manifestations, though. If they don't have the rash or the joint pains early on, they can be quite difficult to sort out. And the next patient, John, is someone who had problems having his diagnosis made because he wasn't the sort of person that people thought of as having lupus disease. And his GP really didn't consider the option.
I noticed I've got some bruising, quite large bruising on the inside of my arms and legs. Couldn't remember having damaged myself. So I called in at my local GP, and apart from a slight comment about my age, he said he would arrange for some blood samples to be taken. And at 2 o'clock that afternoon, he actually came round to my house, told me I got chronic leukemia, and I had to go immediately to the Worcester Royal Hospital. I got there, the following morning they took some bone marrow, and the day after that they said I hadn't got leukemia, but I'd got something called ITP. I can't even pronounce that, but it was ITP with an autoimmune neutropenia. My platelets at this time were about 20 and my neutrophils 0.3, so they were pretty low. His opening comment was, well, I don't know why you've come to see me, because you haven't got what they think you have. He said, if you look at the diagnosis there, the results that you've got, your row and something else, I can't remember what they're called now, he said, that shows quite clearly that you haven't got ITP. No, the bruising stopped not long after I'd started on the prednisolone. And then about a month into the treatment, I started to commit quite large lesions, all over my front, all over my back and legs, and arms, fortunately not on my face, being a vain person. But, and although I went back to see my own GPs, they couldn't explain it, they didn't know what it was. Amongst friends, it's been quite ironic that this so-called Macho man has got this lady's disease.
And the rash that he had was subacute cutaneous lupus, not the malar rash or the discoid rash that are in the American College of Rheumatology criteria. He did have photosensitivity and, on further questioning, mouth ulcers. He also had an autoimmune hepatitis, which was clearly disease-related and not due to drugs. And it's quite common for liver dysfunction to be attributed to drugs, even when it's part of the disease process. Neutropenia and thrombocytopenia we heard about were quite severe, and he had a strongly positive ANA and anti-Rho antibodies. So how common is lupus and how common is it in men? One of the first studies I got involved with when I came to Birmingham back in 1989 was an epidemiological survey of all diagnosed cases in hospital practice and general practice. We found 242 patients in Birmingham, scattered throughout Birmingham and Solihull. The prevalence worked out at 28 per 100,000, which meant that about 1 in 3,500 people in Birmingham, that's adults, had lupus. It was much more common in women than men. 1 in 2,000 adult women had the disease, but only about 1 in 25,000 men. And the gender ratio has remained stuck, despite all the work I've done in Birmingham over the last 20 years. Every study I've done, no matter where the patients were recruited, with a gender ratio of 14 females to 1 male. And I think we're still missing males in this part of the country, because every other study you hear about talks about a gender ratio of 10 females to 1 male. What about the ethnic differences then? Well, everyone was aware that Afro-Caribbeans were more prone to lupus. In fact, patients of African descent in general are. But South Asian patients were not so well recognised as getting lupus. We found that 1 in 1,000 South Asian adult women had lupus, compared to 1 in 500 Afro-Caribbean and 1 in 2,500 white British patients. And the South Asian patients, like the Afro-Caribbeans, had an increased risk of developing renal disease. The Afro-Caribbeans in particular got the disease younger, had more arthritis and less skin involvement. And all these differences were independent of the country of birth, the social class or the place of residence. So in the UK, this is not a disease associated with low social class. For that study, we used the standard American College of Rheumatology classification criteria for lupus, which you're all familiar with. You have to have 4 or more of these criteria at any point in time, and there are no specific requirements to have an immunological parameter. You could have just clinical or just laboratory or a mixture of the two. Now, a number of us have not been very happy with that, and the SLIC group, the Systemic Lupus International Collaborating Clinics that I've been a member of for a long time, were very dissatisfied with this and felt some time ago, and particularly after the results of the phase 2 belimumab study, when about 30% of patients were recruited with no autoantibodies at all, there was a general feeling we needed new classification criteria for lupus that would encompass more of the clinical criteria that we associate with lupus, and that would importantly insist on having at least one clinical criterion and at least one immunological criterion. And Michelle Petrie led on this project, but I was quite involved in it throughout the study. And we have published this last year in Arthritis and Rheumatism. So the new expanded list of SLIC classification criteria for lupus, and these are in the new EMEA, the European Medicines Agency draft guidelines for lupus trials, requires patients to have 4 items out of an expanded list that I'll show you in a moment, with the proviso that at least one must be clinical and at least one must be immunological, or you can have a renal biopsy with at least one antibody, either ANA or anti-double-stranded DNA, because in the past you could have lupus biopsies with lupus nephritis on them, but still not get into trials because you didn't have enough other criteria. So this is the expanded list of criteria. There are quite a few of them. The skin criteria have been divided, importantly, into acute cutaneous and chronic cutaneous. Acute cutaneous containing the malar rash and the subacute lupus rash in particular, the chronic cutaneous containing discoid rash and paniculitis. Interestingly, we were able, on the basis of our regression analyses, to incorporate non-scarring alopecia back in the criteria, which had been in an earlier version of the lupus criteria. And there was a particularly expanded list of neurological criteria with 6 items, which I'll come back to later in the talk. The immunological criteria encompass all the antiphospholipid antibodies and low complement. And I'd like to move next to a patient who had both antiphospholipid antibody syndrome and lupus disease, and took really quite a long time to be diagnosed. And this is Diana. This is her story.
I was diagnosed with a pulmonary embolism very suddenly on a Saturday morning, having had pains in my chest for a week. They did various blood tests and found immediately that I had no white blood cells. This caused some concern, and by the end of a week, they had decided to have a bone marrow scan, because they were sure that it would be one of 2 things, leukemia or lupus. So 1 week after the crisis, I was confirmed that it was lupus. I was 57, it was 2001 in the August. And in 1970, I lost twin boys at 7 months because I had a severe reaction to a bee sting. And they couldn't understand why someone had such a severe reaction, and I think that could have been that probably lupus was present then. But also, I've also had this terrible exhaustion, periods of exhaustion, that was unexplainable. It didn't seem to tie in with heavy workload or having busy young children. I just would suddenly run out of steam, and that's been going ever since I can remember, certainly since my puberty days. About the early 70s, that I definitely had a wolf-shaped infection of the skin just across here. And I was told I was allergic to the cream the doctor had given me, and the dermatologist cleared it all up, but nothing was said about lupus or anything like that at all. They could trace it back to the 2 occasions I'd been to the hospital for surgery. One in 1992 and another time a little bit before that, about 1987. But certainly I had pneumonia, pleurisy, I had kidney problems, liver problems, sinusitis, terrible headaches that was never explained. I was isolated, by the way, for the whole of the 6 weeks. It was like being in prison.
Yes.
And he said, I think you've got to go on steroids. Now, years and years and years ago, I was a nurse, and I didn't like the thought of going on steroids. I heard so many terrible things that had happened to people. And so for 2 or 3 days, I stuck my guns and said, no, I won't go on them. And then he sat me down and he said, well, do you want to stay in here for the rest of your life, or do you want to go out and enjoy your life? And I thought, well, there's no choice, really. And unfortunately, it was a very high dose. It was about 100 milligrams a day. And of course, you have all the weight problems eventually, that start immediately. You feel like a balloon. I think when I came out of hospital, I was about 8 stone, which was a bit lower than my normal weight, which was usually around about 9. And I went up to 15 stone in 4 months, and a lovely moon face. And that really made me feel very miserable. And I came to you in the little clinic in Birmingham, old building in the city hospital. And that's when things started to improve, because you were then able to control what was happening to me.
And I think that was when we started you on cyclosporin,
Yes,
wasn't
it was.
it?
Yes,
Because
it
that was
was
the one drug that wasn't going to affect the bone marrow and wouldn't drop the white cells, and everyone else had been very worried that the other drugs that were so-called steroid-sparing drugs would affect your bone marrow.
And that's when the steroids started to go down quite drastically. And my weight went by magic, and I know that probably every weight watcher will be, well, how did she manage that?
So she had recurrent pulmonary emboli, and I believe that her loss of the twins, unfortunately, at 7 months was related to her antiphospholipid syndrome. There were lots of little clues in the history, unfortunately. And it's interesting to note that Heberdon was aware of patients with recurrent miscarriages. He had one patient who'd miscarried 35 times. He was aware of the concept of women having miscarriages in the 5th or 6th month, not just before 3 months. And although some of these may have had cervical incompetence, it's quite possible some of them had antiphospholipid syndrome. And interesting in particular was the fact that he treated one of these patients with frequent abortions with bark, which is quinine. And he gave it to her while she was breeding, and she went her time, and she went forth with the strongest of all her children. So anyone who's worried about hydroxychloroquine in pregnancy, we've been doing it for nearly 300 years. So I'd like to talk a bit more about pregnancy now, and we'll go back to Nandeep, who you remember was the first patient who'd had a 6-month course of cyclophosphamide intravenously. There are many people who think that patients who've had renal disease should never undergo pregnancy, it's much too dangerous, and that patients who've ever had IV cyclophosphamide in any dose at any age are bound to be infertile. Both of those statements are incorrect. It is true that patients who have had lupus nephritis in the past may be more at risk of having a flare of disease during pregnancy, but as long as they conceive when their disease is well controlled, the risks are very low. You do need to be careful about blood pressure, and they are at increased risk of preeclampsia. And this came out in Nandeep's story, and she was treated in her pregnancy with hydroxychloroquine, prednisolone, and azathioprine.
Everything was fine, I think, until when I got pregnant, I started my ACR and everything started going through the roof. I was getting just more tired. I was off sick from work quite a lot.
But before that, you'd been well, because we talked about planning pregnancy for when you were well, and that hadn't been a big problem for you because your disease was quite well controlled.
I remember you saying that it's fine, you can have a kid to a certain extent when you want to, because your disease is fine, but just let us know so we can do the pre-testing and everything.
That's right.
So that all went to plan.
Good.
So that all worked.
Yeah, but then during the pregnancy you didn't feel so well.
No.
Despite the planning.
I had a cold over Christmas, which for about 2 weeks I was just sleeping it off, and I was given antibiotics in the end because it's just not, I think the doctor was like, it's not worth the risk, we need to give you antibiotics just to suppress it. And I think I had preeclampsia towards the end as well.
Yes.
I was off sick pretty much most of my pregnancy, and then I had I was induced labour 2 weeks early.
Yes.
But my blood pressure was through the roof, and I think in the end I had to have a C-section because of the child's heartbeat kept dropping, and they didn't know what was going on.
No.
And they were like,
we'd been monitoring the baby, and I think it had been well up to that point that the
Yes.
strain of your illness with the preeclampsia as well was beginning to take its toll.
So then they were like, we just need to get the child out. So I was like, okay, it's all a bit of a blur, that
Yes.
part of my life.
Yeah. But the baby was born fine.
And
Yeah, we just had to adjust your tablets again, didn't we? So you'd failed azathioprine after the pregnancy and gone on to mycophenolate at that point.
Yes.
And that seemed to get that settled back down. It was okay. I mean, we had to be a bit careful with the neutropenias. It looks like infections do bring back drops in your white count. So we've had to adjust the doses very carefully and monitor you carefully. But now do you feel you're more or less back to normal how you were before your pregnancy when you had that good spell?
Yeah, I think so. I'm doing a lot more. I'm still getting tired. I still have to draw a line, but it's really weird. I'm just getting a lot more energy now. I don't know if it's positive thinking as well.
I'm sure it helps.
Yes, definitely.
And you're working 4 days a week full time, is that right? 3 days a week full time, and then a full time mother.
Yes. So just drawing a line, and I think I used to put too much pressure on myself where I wouldn't take help from others, and I would make sure I wouldn't get enough sleep. But I'm doing all that now, and
yes,
I'm just letting people look after my son if they want to.
Yes. So you've learned to adjust a little bit, accept some help, pace yourself.
That's right, and that helps
Yes.
big time, because I think 10 milligrams of steroids, the lowest I've ever been on prior to having my son, and I'm on that now, so
Good.
looks good.
So yes, pregnancy can be a bit of a challenge to manage, but with multidisciplinary care and careful control of the disease, patients do reasonably well. This is a report on the first 52 women who came to the dedicated pregnancy clinic that was mentioned earlier that I do at Birmingham Women's Hospital, and our live birth rate was 89%. Our caesarean section rate was 40%. We had a lupus flare, mostly mild and moderate, with skin and joint disease in just under 30%. We had preeclampsia in just under 7%, and hypertension without the proteinuria and edema we associate with preeclampsia in 8%. 20% of our mothers had to deliver early, mostly induced, occasionally spontaneously, and we did unfortunately have 2 stillbirths, one at 24 weeks and one at 39 weeks, and it is our policy to usually deliver these women between 38 and 39 weeks, because we still do get occasional stillbirths at 39 weeks for reasons that aren't always clear. So I'd like to move on now to the assessment of outcome in lupus, which encompasses the assessment of disease activity, damage, and quality of life. You may or may not be aware that BILAG, the British Isles Lupus Assessment Group, was born in Paul Bacon's garden, just down the road from here, back in 1984. And the BILAG index was developed and used in a number of studies over the last 25 years. And it is traditionally recognised as being a system-based scoring, where you have a categorical score, with A being the most severe disease activity, E being the system not involved for each of the systems that we want to assess. And it can be converted, if needed, to a numerical score. Now, there were some problems with it, and there have been changes in medicine and understanding of the disease and terminology over the years, and in about 2003 we decided that it would be important to develop a revised index that would be more discriminating for lupus activity by updating the terminology, the glossary, revising the systems, and particularly including some that were not in the original version, and revising the scoring. And the validation of this was the PhD project funded by Arthritis Research UK for Chi Seng Yi, my clinical research fellow, who's published on this extensively over the last 10 years. The important things that were different about this were that we had a very revised section on neuropsychiatric disease, which I'll come back to in a moment. We included gastrointestinal and ophthalmic. And it's important to note that the BILAG 2004 index is now recommended by the FDA and the European Medicines Agency for clinical trials. It is widely used, both on its own and in combination with other disease activity instruments. Now, the neuropsychiatric features that we wanted to include in this revised index are those based on the American College of Rheumatology nomenclature and case definitions for neuropsychiatric lupus, which I took part in Boston with Matt Liang in 1999. And there are 12 central criteria and 7 peripheral. And the ones that are on this slide in yellow are the 6 that are included in the new SLIC classification criteria for lupus. The one I want to discuss in more detail, however, is myelopathy or myelitis, which is a very devastating condition if not picked up early, and is often treatable, although somewhat refractory to treatment in many cases. And I'd like to go back to Dinah to hear about this.
I realised that I hadn't spent a penny for quite a long time, and that was very uncomfortable in itself. And then I realised that I didn't even feel I wanted to. And also, my legs suddenly started to go very, very dead. I'd squeeze them and there was no feeling there at all. And that really worried me.
Did this develop over a matter of minutes or
No,
hours?
no, I would say it was probably about 2 to 3 weeks when I first felt the different. First of all, it was difficulty in passing urine. Then I felt this funny sensation in my legs that they were going dead. And yet, I still felt safe when I stood up, which I found was very strange. And I thought, well, I first of all thought it was my back that was causing the problem, because obviously if you've got some problem in the back, you can have pressure on the major nerves to the lower limbs. But it wasn't that, because I suddenly realised I couldn't feel anything on my tummy as well.
And your legs were a bit weaker by that stage, weren't they? You were having trouble getting in and out of chairs.
That's right, I was in a wheelchair by then. And we had 2 or 3 attempts at different things to start with, and then one absolutely worked. But the second dose, I felt absolutely exhausted for the first 2 days. I mean, my husband calls it my dormouse days. I think it was a dormouse weekend, actually. And I thought, gosh, I'm going to feel like this for the duration of this thing. I'm not going to do anything or go anywhere. And of course, we had to cancel 1 or 2 arrangements. And then once I'd sort of like slept my life away for 2 or 3 days, I started to feel a little bit more energetic, and that's built up over a period of months. It's been slow, but it has been, I would say it probably took 9 months of that first year for me to say, I really feel well now. I really feel I'm getting somewhere.
And in the previous 6 months, you haven't really noticed any improvement,
nothing at all.
And couldn't go back to doing things. You were dependent on the wheelchair for going out. And now, are you walking independently?
Walking independently. I'm doing all the things I have wanted to do.
So really a complete recovery from that episode.
Yes, and it's better too to make arrangements for when we want to go away or go to a concert or something like that, because in the past, because I've had so many days feeling unwell, although we've made these arrangements, it's often had to be cancelled at the last minute, which is very disappointing for everybody concerned.
So you feel the quality of your life has greatly increased?
Yes, it's much better.
Transverse myelitis in lupus can be inflammatory or thrombotic. She had antiphospholipid syndrome as well as lupus, but her INR was above 3 at the time she developed these symptoms, and it was a more gradual onset than we normally see in thrombotic transverse myelopathy. She failed to respond to the steroids and cyclophosphamide, as she said, but really had a really very impressive response to rituximab. And she's one of 3 patients I've had who failed cyclophosphamide and improved with rituximab. And this has been reported by others as well. And I'll come back to rituximab later. The BILAG 2004 index includes the following gastrointestinal manifestations. Serositis is the most common and akin to serositis around the lung and the heart. We've already mentioned autoimmune hepatitis, and you sometimes get cholecystitis and pancreatitis, although these often get attributed to drugs as well and are actually due to vasculitis from the disease. Bowel involvement is less common, but certainly occurs from time to time, and we've got a case presentation on another of our bowel involvement patients in the Meet the Expert session on Thursday. What I'd like to talk about now is intestinal pseudo-obstruction. And this is Seima's story, and she presented to me with
I was 17 and 18-year-old. I started losing my hair, which my hair was really thick and long. It was beautiful. Suddenly I started having lumps and a lot of vomiting, which was bile.
Yes.
I couldn't eat anything, started losing weight, started having acute abdominal pains, keep on visiting the doctors, and suddenly I end up having operation gallbladder. But things wasn't sorted, nothing. Things were getting worse and worse. Vomiting, it just didn't stop. I was 2 days home, 4 weeks in hospital, and they tried all their best. They couldn't just diagnose nothing out. I had another appendix.
Yes.
Which it was an appendix.
Again, they looked at it in the laboratory and nothing was wrong with it.
Things went more bad.
Yes.
I started losing a lot of weight. I had no hair.
Really?
I had a lot of constipation. I wasn't going to the toilet. I had another operation. My third operation.
Because at one point I think they thought you had something called adhesions, some scarring, and that was affecting the bowel.
Yeah. It was.
But even when they looked for that, they didn't find that either, did
no,
they? And they didn't really understand what was wrong with you.
No. I had a big operation from there to there, and still things wasn't settling.
Well.
A lot of joint pains. A lot.
With stiffness in the mornings.
Like I was like this in the mornings.
Yes, the joints became swollen,
stiff,
wouldn't move.
Yeah.
And did you have any rashes?
Very rare. They knew I had lupus. They knew I had lupus.
Yeah.
But I wasn't on any tablets.
No, no treatment at that time.
No treatment except just one tablet, which was steroids.
Yes, and then they started the steroids and it still didn't help you, did it? I think you were on 2 tablets a day,
yes, I was on 10 milligrams a day. I was so weak, so weak. I came to your clinic. I saw you once. You introduced me to another doctor and yourself. And I had some tests, and then you put me on some steroids. You put me on a medication course. I think in a week I was
I was back home.
Yes.
I was back home.
Never had to be admitted to the hospital again.
After about 10 years. Yeah, it's my 11th year seeing you, Dr. Gordon. I've never been as an inpatient, but I always come as an outpatient.
Yes.
Yes, I'm so happy. It's made my life absolutely change. I'm living a normal life.
It's very important in patients who are vomiting and have any degree of gut involvement to use intravenous steroids because they obviously don't absorb the oral ones. And this condition of subacute obstruction not only affected her small bowel but also her ureters, and she used to get intermittent obstruction of the ureters and of the small bowel, causing the vomiting with dilatation visible on X-ray and ultrasound. And the diagnosis was confirmed by CT scan, and she had vasculitis in the wall of these tubular structures. And this is a rare condition, but it does crop up several times. Gosh, what happened there? What everyone dreads. I hope somebody in IT can fix it. Thank you. So she was treated with steroids and azathioprine and later switched to cyclosporin, went into remission, and is now just on steroids and hydroxychloroquine in low dose. The ophthalmic manifestations of BILAG 2004 are listed on this slide. There's a picture here of episcleritis on top and keratitis below, but it's retinal vasculitis which can be the most severe. Emma was a patient who presented in 2007 with an inflammatory arthritis, another one of the patients first diagnosed as rheumatoid, but it was actually lupus arthritis. She also had alopecia and fatigue that didn't respond to thyroxine replacement for her hypothyroidism, but got better when she was treated for lupus. And she also was found to have evidence of lupus nephritis. She had our original traditional regime of IV cyclophosphamide, later switched to azathioprine, and continued with low-dose prednisolone and hydroxychloroquine. And then 4 months later, she presented with another episode of illness with fatigue, some pericarditis, and then acutely got unwell with vertigo, blurred vision, and loss of vision in the left eye. And investigations showed a left panuveitis and retinal vasculitis with the fundal images shown on the screen, loss of visual acuity down to 1 out of 60. And she was given IV steroids and cyclophosphamide. And she seemed to be picking up, and she was discharged home a week after having cyclophosphamide. And this is what happened next.
I remember coming down the stairs on my bum. I couldn't walk down the stairs. I was really giddy and come downstairs on my bum. Walked into the room, saw a little girl give me a big hug. And remember glancing at the television and seeing the Formula 1 racing was on. And thinking, there's something not right. I can't see that telly properly. I don't know what's happening. And sort of made my excuses quite quickly that I didn't feel very well. My friends disappeared to the point where I was shouting my husband, Neil, there's something wrong, there's something wrong. When my husband come in, I said, it's happened to this eye, Neil, I can't see. And they immediately knew that what had happened to this eye had then happened to this one. Got me straight up onto the ward. I was still in the same bed that I'd been discharged from the day before. It hadn't even been filled. And I think you were called in. I think Professor Murray was called in and immediately started on the treatment again.
And then we arranged to get the rituximab because it didn't look like the cyclophosphamide and the steroids were doing any good.
Yeah.
So you did start on rituximab?
Yeah. Within,
I think, 2 or 3 days.
Oh, right, that's it then, yeah. And I think this eye wasn't affected as severely as this eye because as soon as this happened, we were very quick with what happened. We were straight over city. So they managed to save this eye as such. There is still an element of scar in there. And I am now, following that week, Professor Murray actually registered me officially blind, partially sighted. And that's how I've remained since, with no transport, no driving anymore, nothing.
No, huge impact on your life.
Huge, massive impact.
So she did have very poor sight, but it had improved after her treatment. She had 2 doses of cyclophosphamide and 2 of rituximab, as well as oral and intravenous steroids. And her vision at 6 months improved to 636 on the left and 624 on the right, and it's remained at that level. But she has been able to pick up her life, and the rest of her disease went into complete remission after that treatment. So over the years, we've had to consider how to change treatment for lupus patients. When I arrived in Birmingham, as you heard, we were still using oral cyclophosphamide and very high doses of oral steroids, and these are both associated with a lot of toxicity, oral cyclophosphamide having even more toxicity, particularly with the risk of cancer compared to intravenous cyclophosphamide. And we did report on a study on intravenous versus oral cyclophosphamide, even though we didn't achieve our target numbers for that trial. And we went on to do a lot of work with various people on mycophenolate mofetil and did an open-label study in the UK, one of the first reports of mycophenolate mofetil in lupus nephritis. And I got involved in the ARMS study, and that showed, although no benefit, or sort of no greater benefit of MMF, it was at least as good as cyclophosphamide in the induction of lupus nephritis, and the more recent publication has shown that mycophenolate is better as maintenance therapy than oral azathioprine. And certainly our practice and the recommendations from EULAR SLE Task Force and the American College of Rheumatology is that mycophenolate mofetil should now be used in preference to cyclophosphamide when available because of its lower toxicities, and certainly it does appear to be as good as. There will never be a trial, as far as I can make out, comparing them directly, and this is the best evidence base we're likely to get. We've also done quite a lot of work on cyclosporin A, and we've published a trial that the BILAG group did on cyclosporin A versus azathioprine, showing that there was no greater toxicity with cyclosporin A as long as you followed the monitoring guidelines, that both were equally good or equally bad, depending on how you look at it, as steroid-sparing agents. But in practice, we find cyclosporin A very helpful for patients with hematological problems. Now, the rituximab story is one that many of you will be already familiar with, but for anyone who isn't, we have a dilemma here. There is an increasing number of reports, I've just given you some, and there are many others in the literature, and a recent systematic review has confirmed this, showing that rituximab can be beneficial, or appears to be beneficial, in patients who have not responded to traditional therapy when it's used in addition to standard therapy, and it does allow steroid reduction, often quite significant steroid reduction. But the clinical trials, the randomized placebo-controlled trials, Explorer, the non-renal study, and Luna, the study in lupus nephritis, did not meet their endpoints. These were trials which were done where rituximab was added on top of conventional therapy. They both had a lot of steroids on board, and they included patients who had not been refractory to previous therapies. So they weren't comparing the same patients as was reported in the literature on the open-label basis. The Explorer study, the non-renal one, did show some benefits, and planned subgroup analysis did show some benefit in African American and Hispanic patients and in patients on background methotrexate. And some exploratory analyses suggested that there was a change in serological markers, which was also seen in Luna, the renal study, and a trend to reduction in BILAG A flares, the more severe flares that we need to stop in order to prevent damage. So we do need more trials of this agent in particular, and I'm pleased to let you know that Arthritis Research UK have agreed to fund a new study of rituximab in lupus nephritis. It's a very novel regime which is aiming to be steroid sparing, in that the drug will only be given with a very small amount of intravenous methylprednisolone at the beginning and with mycophenolate, and no oral steroids. So watch this space. The study is being set up by Liz Lightstone and is due to start this summer. We do need to get new therapies for lupus. The damage that has accumulated from the disease and from the drugs used to treat it is considerable. And this slide shows the cumulative damage in 467 of my patients over time. At least one item of damage using the SLIC ACR damage index was sustained by 39% of patients. And the most common system to have damage in was musculoskeletal. A lot of this was due to osteoporotic fractures, and you won't be surprised to hear after the 100 milligrams of prednisolone that Diana was given. She had extremely low bone mineral density and developed multiple vertebral fractures, which is why the first thought when she had problems with numbness in her legs and weakness was she might have sustained another fracture and a disc prolapse or vertebral pressure on the spinal cord, but it was indeed myelitis. We've looked recently, and the full details of this data is presented as a poster tomorrow by Chi-Seng Yi, but we've now looked at our accumulation of damage over 20 years in the Birmingham cohort. We've examined 382 patients who were recruited within 3 years of diagnosis, and we have shown that there is an increased risk of damage in patients who had BILAG A or B scores in neuropsychiatric and renal systems, and independently in those treated with cyclophosphamide or steroids, or both, but this in a multivariate multivariate analysis, so these are all independent risk factors. We were able to confirm an observation made by others previously that hydroxychloroquine appears to be protective against damage. And there was a trend, but not definitive at this stage, for mycophenolate mofetil to be safer, certainly a lot safer than cyclophosphamide. So you need to go back and see the data on that tomorrow morning. In terms of mortality, unfortunately 37 patients have died in this inception cohort. The biggest cause of death is infection, and the next most common cause was cardiovascular disease, and both of these may in part be attributed to steroids, although patients were certainly most at risk if they'd had bad disease in the past and didn't necessarily suffer their infections or their cardiovascular events when they were on a lot of steroid. We've managed patients increasingly with care and attention to hypertension and hypercholesterolemia, and there isn't time to show you the results of our studies on those risk factors. I'd like to move on in the remaining minutes to quality of life and how we might change things further in the future.
The next time I relapsed, it was physically debilitating and painful, but psychologically it took a lot more courage to try and get through that again, because it was then that eventually I had to give up my job. I had to give up my career. One of the most devastating things that I'd worked so hard for this career, gone to university and studied a long time for it, and then, you know, to have to finally say, and it was, you know, my boss was quite good, he allowed me to make the decision to say that finally I just could not do this anymore. And so having to give up work affected me financially, so I had problems you know, financially, housing and, you know, my home and mortgage and all the rest of it. And so it impacts on your lifestyle, it impacts on you financially, it impacts on your career, it impacts on your relationships, both with your family, your partner, friends. And being a very independent person, it was very difficult for me to start asking for help, which I just found nigh impossible to do at first.
Impaired quality of life occurs across all the domains of the short form 36. We showed this in a collaborative study with David Eisenberg's group at University College Hospital in London over 15 years ago. But the trouble with the short form 36 is it doesn't always capture things that are important to patients with lupus. And body image is something that many of them feel very strongly about, both due to the effects of the disease and the treatment. This is Lisa.
You know, I remember standing at the bars that they have in physiotherapy to hold you up, and looking at myself in the mirror and just not recognising myself. You know, I just didn't recognise, I was just a little thin thing with no hair, full of rashing. And I thought, no, I never ever want to look in that mirror again and see that person. And, you know, luckily my parents lived in a bungalow at the time. I went back to live, obviously they wouldn't discharge me from hospital without having that care plan in place. And the speech therapist came to see me, and there's a photo of me on my parents' mantelpiece on fire of when I went to Paris the year before, literally 12 months before, so that was the July beforehand. And the lady came in, unbeknownst to her, not meaning to be offensive, turned to my mum and said, "Who's that? Is that Lisa's sister?" And my mum said, "No, that's Lisa." And she looked at me and she didn't recognise me either. She couldn't equate the two people. You can either hive yourself off from everybody and become a hermit, or you have to say, well, you know, eventually I will get better. Right, not right now, but eventually I will get better. And yes, people are going to look at me in the street. And, you know, I went into town with my mum to Worcester because it's quite flat and easy to get around. And I was at the top of maybe 5 steps coming down to a department store. And this old man, if he was 90, I'm not doing him a disservice, came up to me and said, "Do you want any help?" Yes.
So, as I said, the short form 36 really doesn't capture some of the problems we've heard about from the patients. Body image I've addressed in part, we'll come back to that in a moment, but also planning. Diana mentioned the problem of planning and how much better it was once she'd had a treatment that seemed to give her better disease control. There's also the issue of intimate relationships, important, particularly if patients want to have children, and the burden to others and the need to rely on others to get around. And patients have to learn to manage their disease and their activities and plan how they're going to do things.
Put sunblock on if I'm on a sunny day. I know, and all my family know, that there are times when I just have to go for sleep. And so it's just become become the norm, the new norm, really. So I would say I wasn't, compared with a lot of people who've got lupus, I wouldn't say I was terribly badly affected. I mean, you get used to it. There's a pattern to it. If there's a flare-up, you take prednisolone and then you reduce it and you take some other kind of immunosuppressant, and it's become a pattern now. Yeah. It's 40 years later. The facial scarring and rashes, particularly when at times when they have become very livid, that, yes, it makes you very self-conscious. It would have been nice, you know, it's easier, I guess, for a woman who can put makeup on or whatever, but the attempts I've seen at putting makeup on men look worse than the problem, so I've not bothered.
So we are making some progress. The disease now has a 10-year survival of at least 90–95%. In the 1950s, before corticosteroids, there was a 50% 4-year survival. Patients do have to plan for the disease, and they are distressed by the effects of the disease on them and the effects of the drug treatment in many cases. Many of the patients have to give up their careers. I've been involved in a study by Lupus Europe where they did an online survey, got 2,070 respondents. 52% of them said they were employed. 70% said of that 52% that they'd had to, that lupus had affected their career, and 16% had had to change career, and 29% had had to work flexible hours because of the disease. But there is hope with some of the new therapies.
But with regards to the lupus, there's just nothing.
And now you're getting yourself organised with new hobbies and new career aims.
I did new career aims. I started when I was officially made redundant. I just, like I say, I hadn't got a clue what I was going to do. And I'd got a bit of an hobby where I write poetry. And I had a friend of mine who wanted a card for her daughter and son-in-law's first wedding anniversary. She asked me to write a poem, and I ended up making her a card, not just a poem, a beautiful, beautiful card. And from that moment, I've never looked back, because now I actually have a business.
So you can have new careers even when you've lost your sight, or almost totally lost your sight. The challenges for the future are to improve the outcome of the disease by treating and preventing active disease more thoroughly without developing infection, improving patients' quality of life and functional activities, and preventing damage. And we do have some new therapies.
Pretty quickly after Matthew was born, and I was still on maternity leave. Then I went back to work, and it became quite clear, very evident, very early on, something wasn't right, because yet again I was coming down with infections, and the fatigue was unbelievable, and I was struggling to actually maintain a normal life with it. And by the time I came to come on the clinical trial, I couldn't dress myself, I couldn't get in and out of the bath. I'm rashing over a good 25% of my body, hair loss everywhere, mouth ulcers, you know,
lots of joint pain and
joint
stiffness.
pain. I couldn't get in and out of a chair without help. Couldn't drive. Couldn't really care for my son, and that was the issue. So that.
And you weren't thinking very clearly either.
Oh no, memory stutter, fall over, have blackouts. You know, I wasn't safe to. Certainly, it's not safe to be let out on my own. Yeah, certainly not. I couldn't do shopping. I couldn't do anything normal whatsoever. You know, I couldn't get in a shower without Nick looking after me, because he said, "What if you fall down?" And it was as bad as that. And I couldn't do any of the neurological tests that you used to do. You know, it was like a 2-year-old doing it, really. Stuttering, forgetting where I was going, forgetting what day of the week it was. I used to have to ask people, "It's Thursday today," and then I have to think, "Yeah, they're right. It is Thursday." You know, forgot everything. Had to write everything down. I couldn't do the nose to finger test whatsoever. I could, not very well. I could probably get it on my nose, but certainly not to the finger. And that's the situation I was in as I came to start the clinical trial.
Yeah. And it had been like that for quite some length of time.
Yes.
Because we actually thought it was fixed. and that you'd
Yes.
had an episode of active disease. We'd tried to stabilise it with the other drugs, with the steroid drips that had always worked before, the mycophenolate, hydroxychloroquine, and you seemed to be in a stable state, but with what we thought was going to be damaged by that stage, and we weren't convinced you would recover. But the rashes were going on, the joint pains and the stiffness was going on, the hair loss, the mouth ulcers.
Yeah.
And really for those aspects, we got you into a clinical trial.
So it was on the basis of the musculoskeletal and mucocutaneous features. She had a trial. She was in a 3-month trial, double-blind, placebo-controlled study. We know she did have active drug, and she went on into an open-label extension study.
You then put me on what you knew, obviously, was the correct dose of the drug. In combination with that treatment and that drug, that level of steroids, by the following September, and I know it sounds really slow looking back, but every month is a bonus to a degree, I was starting to get better. So within a 10-month period, I'd started to feel the benefit of it. I certainly felt neurological benefits of it very quickly. The skin problems, a little bit more tricky, and I did go and see a dermatologist, and the only other option was to come off the drug trial. And because I was seeing such other benefits of it, I wasn't prepared to do that just for the skin. I said, well, I'll rather put up with the skin issue, be able to walk around, talk, not fall over, not pass out, remember where I'm going, have all the other benefits, and then have to deal with the skin at a later stage. But the skin has been the last thing to clear up, oddly enough.
But eventually has.
And it eventually has cleared up.
And you have reduced the steroids.
Yeah, now
and kept them low.
10 milligrams of steroids for 12 months.
Yeah, which is the lowest you've been.
Yeah, since before I was pregnant.
Yeah.
Yeah. Which is in 2003 so 10 years. It dealt with the walking issue for me, the joint pain, the muscle pain. It stopped the hair falling out, and finally it's dealt with the skin, and it's done them really in order of priority. And this is the first time for 13 years that I've had 5 months free of no rashing ever, and no symptoms of rashing, no suggestion of rashing whatsoever. So that's an excellent result, really.
And what was the drug? This was epituzumab. Those of you who came to this meeting last year will have heard me present this data in more detail. It's a monoclonal antibody to CD22 receptor. It upregulates CD22 inhibition of the B-cell receptor, which means that it modulates the B-cells, downregulates them, and reduces B-cell trafficking. And the important point of the data in this phase 2 study was that 4 doses of 600 milligrams weekly had a more than double response in terms of the responder index used for this study. It's a BILAG-based composite responder index, so nearly 46% of patients improved compared to 21% given placebo. An alternative way of giving the same dose, 1,200 milligrams every other week for 2 doses, or total dose still of 2,400 milligrams, was almost significant. And these 2 dose regimes are currently under study in a phase 3 study. We certainly don't need to use the 1 milligram per kilogram per day high-dose oral prednisolone regime anymore. I believe intravenous methylprednisolone is safer, and judicious use of other disease-modifying drugs will help patients. Mycophenolate mofetil in particular seems to be very good, both as an induction agent and a maintenance agent for both renal and non-renal lupus, and we're hoping that it will be associated with less damage in longer studies. I think the biological studies, as I've already alluded to, provides more hope for even better outcomes in the future. At the moment, active disease still impacts significantly on patients' lives, but with careful management and with multidisciplinary care, they can have children, they can have new careers, and I think life is looking rosier in the future. Thank you very much.